Hello, and thank you for watching our PowerPoint presented by Alicia Aguilar and Christine Glave-Smith, representing the United States University, on the topic Diabetes Mellitus for our class F&P 596 for primary health of chronic clients, families across the lifespan, with our professor Lindsay Olson-Mack. Diabetes definition is a metabolic disorder characterized by chronic hyperglycemia and disturbances of carbohydrate, fat, and protein metabolism resulting from insulin action or secretion defects, or both. Hyperglycemia is the defining biochemical feature. Most common forms are type 1 and 2, type 1 being autoimmune, and type 2 common, most strongest genetic link. Approximately 5% account for all diabetic patients at type 1. Childhood onset is typically less than 20 years but can occur at any age, and peaks at age 4 to 6 and 10 to 14 years. Highest prevalence in non-Hispanic whites, and the incidence of childhood type 1 varies based on age. Bimodal peak, which is usually 4 to 6 and 10 to 14 years, and geography, rising worldwide, increase in latitude, highest in Finland and Sardinia, and lowest in China and Venezuela. It's also varies based on gene, which involves many genes, but the strongest for type 1 is located on the chromosome 6. And it's also race-related demographics, which is type 1 highest incidence in whites and lowest in Chinese. And the sex, males at greater risk in high incidence areas, females greater risk in low incidence regions. Type 2, however, the estimated prevalence in the U.S. is 9.1%. Adult onset typically greater than 40 years. Mean age of onset is decreasing though. Highest prevalence in Hispanics, Native Americans, Asian Americans, African Americans, and Pacific Islanders. In 2017, approximately 462 million individuals were affected by type 2 diabetes, corresponding to 6.28% of the world's population, or a prevalence rate of 6,059 cases per 100,000. Type 1 autoimmune beta cell destruction in genetically susceptible individuals, the etiology and risk factors are as follows. HLA association with the DR3 and DR4 positive patients are 4 to 6 times more likely to develop type 1 diabetes. Association with other autoimmune conditions include Hashimoto thyroiditis, type A gastritis, celiac disease, and primary adrenal insufficiency. Type 2, hereditary and environmental factors play a significant role in the disease process. It also has an important association with metabolic syndrome. Risk factors are obesity, high-calorie diet, high waist to hip ratio, physical inactivity, first-degree relative with diabetes, ethnicity, hypertension, dyslipidemia, and history of gestational diabetes. Some clinical features here for the differences between type 1 and type 2 are listed here in this chart. As you can see, type 1, the frequency is 10 to 20% versus type 2, 80 to 90%. The age of onset is usually earlier in type 1, and type 2 is usually later or greater than 40 years old. Type 1 onset is usually abrupt and severe, whereas type 2 is insidious and gradual. Usually patients who are type 1 diabetic are normal in weight, and type 2 obese, and can also be non-obese. Family history is less than 20% on type 1 and approximately 60% in type 2. Diabetes and identical twins can be 50% concordance and 80% concordance in type 2. The pathogenesis for type 1, autoimmune destruction of beta cells, whereas type 2 has an insulin resistance compared insulin secretion. The islet of cell antibodies is existent in type 1 and not in type 2. The blood insulin level is decreased in type 1, and type 2 can be normal or increased. The islet cell changes. Insulin cell depletion type 1, and no insulitis in type 2. Amyloidosis is infrequent in type 1, but is common in type 2. The clinical management for type 1 is usually insulin and diet, and type 2 is usually diet, exercise, and oral prescription or insulin. Acute complications include for type 1, ketoacidosis or DKA, or type 2 hyperosmolar coma. Grossly, the pancreas is composed of 4 main parts, namely the head, the neck, the body, and the tail. The head comprises the head of pancreas proper and uncinnated process. The pancreas spans the upper abdominal part behind the stomach, with its tail ending adjacent to the spleen on the left upper quadrant. The pancreatic islet cells from the pancreatic locale where the central endocrine hormones are secreted, and the rest of the pancreas is largely exocrine. The normal adult pancreas contains about 1 million islets, accounting for 1 to 2% of total pancreatic mass, which are scattered throughout the exocrine parenchyma. The core of each islet consists of beta cells, 60 to 70%, that produce insulin and amylin, and is surrounded by a cortex of endocrine cells that produce other hormones, including glucagon, somatostatin, pancreatic polypeptide. From this information, it is evident that the main function of the islet cells is insulin production. Insulin is secreted by beta cell of the pancreas. Insulin secretion is controlled by blood glucose concentration. Beta cells have GLUT2 that permit a rate glucose influx proportional to blood concentration. Once inside the cells, glucose is phosphorylated to glucose 6-phosphate by glucokinase. Glucose 6-phosphate is oxidized to ATP, which inhibits ATP-sensitive potassium channels of the cell. Closure of potassium channels depolarizes the cell membrane, opening voltage gated calcium channels. Influx of calcium results, leading to fusion of insulin containing vesicles with cell membrane and exocytosis of insulin into extracellular fluid with resultant effects. As you can see in the chart here is the listing of pathophysiology for type 1 and type 2. Normal insulin physiology, secretion. Insulin is synthesized in the beta cells of the islets of Langerhans. The cleavage of proinsulin precursor molecule of insulin produces the C-peptide and insulin, which consists of 2 peptide chains, A and B chains. Action. Insulin has a variety of metabolic effects on the body, primarily contributing to the generation of energy, reserves, and glycemic control. Carbohydrate metabolism. Insulin is the only hormone in the body that lowers the blood glucose level. Protein metabolism stimulates protein synthesis, stimulates amino acid uptake into cells, inhibits proteolysis. Lipid metabolism maintains a fat depot and has an anti-ketogenic effect. Electrolyte regulation stimulates intracellular potassium accumulation. Type 1 diabetes, pathophysiology, the initial genetic susceptibility plus environmental trigger, often associated with previous viral infection as earlier outlined in previous slides. Next, the autoimmune response with production of autoantibodies such as anti-glutamic acid, decarboxylase antibody, anti-GAD, that target insulin-producing cells, then progressive destruction of insulin-producing beta cells in the pancreatic islets of autoreactive T cells. Destruction causes 80 to 90% of the beta cells. Absolute insulin deficiency causes elevated blood glucose levels. The type 2 pathophysiology contains 2 major mechanisms. Type A, letter A, peripheral insulin resistance, which is initiated by numerous genetic environmental factors, results in central obesity, increased plasma levels of free fatty acids, which impairs insulin-dependent glucose uptake into hepatocytes, myocytes, and adipocytes. Increased serine kinase activity in liver, fat, and skeletal muscle cells. Phosphorylation of insulin receptor substrate decreases the affinity, and then decreases expression of GLUT4 channels, which then decreases the cellular glucose uptake. The pancreatic beta cell dysfunction starts with accumulation of proamylin, the islet amyloid polypeptide in the pancreas, and then decreases the endogenous insulin production. Initially, insulin resistance is compensated by increased insulin and amylin secretion. Over the course of the disease, insulin resistance progresses, while insulin secretion capacity declines. After a period of impaired glucose tolerance with isolated postprandial hyperglycemia, diabetes manifests with fasting hyperglycemia. Some clinical features for type 1 and type 2. Type 1 is sudden, such as DKA, often the first manifestation, and as children may present with classic symptoms and acute illness. For type 2, it is gradual and insidious. Most patients are asymptomatic. Usually dehydration in elderly is the main classic symptom. Symptoms of complications may be the first clinical sign of the disease. And some characteristic features have classic features such as polyuria, polydipsia, polyphagia, and non-specific features are fatigue, visual disturbances such as blurred vision, calf cramps, poor wound healing, pruritus. And type 1, you can have weight loss, and type 2, benign anketosis nigricans. The diagnostic approach in the routine testing and diagnosis of diabetes, the following tests are vital: the random blood sugar, hemoglobin A1C, urinalysis to assess for glucose, ketones, and proteins in urine, such as microalbuminuria, an early sign to detect nephropathy. Glucosuria, testing urine for glucose, does not suffice to establish the diagnosis of diabetes. And ketone bodies, usually accompanied by glucosuria, positive in acute metabolic decompensation in diabetes, such as DKA. Urine albumin excretion. This test can help you assess for renal complications of hyperglycemia, such as diabetic nephropathy. Urine protein, urea electrolytes, and creatinine, plus estimated GFR rate to assess the renal function. And remember, diabetes causes nephrotic syndrome. You can also test for thyroid function tests such as TSH, T3, and T4. The lipid profile, aim for total cholesterol level below 4, of course. Additional tests may include specific autoantibodies for diabetes type 1, which is the anti-GAD antibodies, and the anti-tyrosine phosphatase-related islet antigen, and also the islet cell surface body. C-peptide. Decreased C-peptide levels indicate an absolute insulin deficiency for type 1, and increased C-peptide levels may indicate insulin resistance and hyperinsulinemia, which is type 2. A single random blood glucose level can also, which is greater than or equal to 200 milligrams per deciliter, is sufficient for diagnosis. Alternatively, a pathological fasting plasma glucose test, oral glucose tolerance test, or hemoglobin A1C test establishes a diagnosis of diabetes. If hyperglycemia is high enough to suggest but not confirm a diagnosis of diabetes, two similar tests, either from the same sample or from a separate test sample, will confirm the diagnosis. Some treatment includes treatment goals for both type 1 and type 2 are as follows. Treat with hyperglycemia through administration of insulin or oral hypoglycemics. Treatment of hypertension and dyslipidemias using antihypertensives and antihyperlipidemic drugs as needed. Treatment and prevention of both macro and microvascular complications. Doing some lifestyle modification goals include increase physical activity to improve insulin sensitivity and reduce blood glucose, quitting smoking, diet modification, and balanced diet intake, such as intaking approximately 55% of carbs, 15% protein, and 30% fat, eating small, frequent meals, and doing a high fiber diet. In this chart, it shows the available insulins and their classifications. It shows their approximate time, their peak time, their half-life for the premix, long, intermediate, short, and rapid. In this chart, we can see a therapy algorithm for type 2. The general measures are for type 2 are as follows: exercise, weight reduction, medical nutrition therapy, self-management education. Monotherapy usually includes first-line metformin. A dual therapy can include metformin and a second oral hypoglycemic. A triple therapy can include a third hypoglycemic plus an injectable and a nightly basal insulin added. And usually those can be either Lispro or Lantus. And a combination of an injectable therapy is usually metformin, a mealtime insulin, so before meals, and of course a nightly basal insulin as well. Thank you for listening to both Alicia Aguilar and Christine Glaze Smith PowerPoint presentation on diabetes. Thank you so much for your time.